Good morning, and welcome to the 11th Annual Hicks-Harris-Ferguson Multiple Myeloma Symposium. We're grateful to be hosting this virtual event to celebrate Multiple Myeloma Awareness Month. I'm Jerry Ravish, and I'll be your MC for today's symposium. It is truly an honor and privilege to be part of such a wonderful initiative focusing on multiple myeloma and the minority community. This year's symposium will focus on COVID and multiple myeloma clinical trials, and we're excited to bring to you this inaugural series entitled My Personal Journey with Multiple Myeloma. It was curated from the numerous comments from our 2021 symposium, recommending more people living with this disease to share their stories. We have some dynamic presenters today from across the country ready to share their resources with you. So let's get the program started. Please welcome Reverend Mornay Meyer, Senior Pastor at St. Paul AME Church in Columbus, Ohio, for our opening prayer.
Heavenly Father, as we gather today, we firstly proclaim your righteousness and invoke your presence as we praise you all day long. Your faithfulness, love endures forever, and your grace and your mercy never cease. In this day, we declare one more time and concur with the hymn writer that says, "Great is your faithfulness. Who can compare to you?" Lord, we exalt your holy and righteous name. We declare that there is indeed none like you. Lord, as we gather here today at this symposium to speak on multiple myeloma, we thank you for doctors and health workers and scientists, researchers, and these speakers and educators that have come to and on this virtual space to pour into us their knowledge and skills. Lord, we thank you for watching over those persons who have been diagnosed with cancer and especially with multiple myeloma. Thank you for your healing power. Thank you, Lord, for declaring us overcomers by the blood of the Lamb and by the word of our testimony. Lord, thank you for those who have gone before us and left this rich legacy. Thank you for the lives of Hicks and Harris and Ferguson and Boyce and many others. Thank you for their families, for keeping their memories alive. Bless this virtual space. Open our hearts and our minds. In Jesus' name we pray. And the children of God say, amen and amen.
Thank you, Reverend Meyer, for that inspirational blessing over our symposium. Now, before we begin, a few housekeeping items. This program was pre-recorded. We encourage you to use the chat box to make comments about the program and presenters, request more information, etc. Some of our presenters will be joining us and we'll try to answer any questions during the program. But if your question is not answered, responses will be posted to our website after the program. A digital program was sent along with the link to access today's symposium. Please refer to it for today's agenda, speaker bios, and other pertinent information regarding the event. There will be chat raffles throughout today's program, giving away various gift cards. These chat raffles will be randomly drawn from those actively participating in the symposium, and winners will be announced through the chat box and through the email provided at registration. So share your thoughts and comments. We will continue our practice of raffling off the multiple myeloma quilt today. All you have to do is complete the short symposium evaluation. It will automatically launch after the event to the email that you used to register. One winner will be randomly selected once all evaluations are received and verified. The winner will be notified no later than April 11th by email or phone. The evaluations are very important. They will assist the planning committee with curating what the symposiums will look like. They'll also provide pertinent information that our participants need. So please don't forget to complete yours. And now, without further ado, let's move on to our opening remarks with Jerome Ferguson, HHF Planning Committee Vice Chair. Mr. Ferguson.
Good morning, and welcome to our 11th Annual Symposium. On behalf of our committee chair, Ms. Joanne Harris, and the other members of the Hicks, Harris, Ferguson Multiple Myeloma Symposium, I bring you greetings. We can't thank you enough for joining us on this last Saturday of Multiple Myeloma Awareness Month. We have prepared an outstanding and informative program for you today, which includes experienced multiple myeloma patients, caregivers, and physicians. We hope that you will receive new information and resources to assist you in your own personal journey with this disease. This symposium is named in honor of 3 individuals who had multiple myeloma and were community leaders. Eleanor Victorian Fraser Hicks, the Reverend Richard L. Harris, and Lugenia Pierman Ferguson. Our mission is to further the advancement of information about this disease to communities of color across the country. We appreciate your support and hope you enjoy our program. Have a blessed morning.
Thank you, Jerome. This annual event started in 2011 because of the commitment and passion of the late Cheryl Boyce, who also had multiple myeloma. The Hicks-Harris-Ferguson Multiple Myeloma Symposium is the oldest and largest African American event in the nation. We'd like to take a moment of silence now in honor of Miss Boyce. Her legacy lives on through the hard work and dedication of the Volunteer Planning Committee. You can find their names in your digital program booklet. Thank you, committee, for all that you do and continue to achieve on behalf of those diagnosed and living with multiple myeloma. So let's get the symposium started now. For our first session, Multiple Myeloma Care during the COVID-19 pandemic, we are honored to welcome Dr. Brandon L. Blue, MD, Assistant Professor, Malignant Hematology Department at Moffitt Cancer Center, Tampa, Florida, and our own Dr. William Hicks, our retired oncologist here in Columbus, Ohio, to share ways to keep safe while in treatment and remission. Please welcome Dr. Blue and Dr. Hicks.
Dr. Brandon Blue, we are so happy to have you here and have your participation in the Hicks-Harris-Ferguson Multiple Myeloma Symposium. We've heard a lot about you through a colleague of yours, Dr. Ebony Boyce Carter, and she had nothing but great things to say about you and the training experience that you had over in St. Louis at Washington University. We know that you are an assistant professor of malignant hematology in Tampa. And we are just, again, elated to have you with us to discuss what we think is an incredibly important topic. Obviously, multiple myeloma is an incredibly important topic itself, but we like to delve a little deeper and look into what's happening with our multiple myeloma patients who have not experienced COVID yet, and those who have experienced COVID, and whether their experience with treatment is altering their experience with COVID. Now, I've said a lot, but I think, we can take our time and just go through this, and you can help our patients, and importantly, not only our patients, but their families. I just have to say this for a second. As you know, I'm a pretty old guy, and so when I started treatment of patients with multiple myeloma, we had survival times of 2 and 3 years. And of course, we had limited resources, basically various forms of chemotherapy. Now we have all sorts of things like immunotherapy. And before I left practice, I had patients who are surviving 20 years plus. So we're making progress, but we still need to go further. We still need to push toward that cure. So, Dr. Blue, let's hear from you.
Thank you so much for inviting me to come out and talk today. I am really excited to talk about this because I see multiple myeloma every day. And then imagine the surprise where we take a cancer that's unfortunately having big implications on people and now introducing, unfortunately, a deadly pandemic. So I really want to talk about really how the two of those things together are really making changes. So today we'll talk about some of the implications that really COVID has had on the myeloma community. One of the main things that I wanted to talk about is how did the treatment change? Like, what were some of the management decisions that I had to do as a myeloma doctor and other providers had to do during COVID that might not necessarily be how things were before the pandemic actually broke out? Just for those who might be a little bit unfamiliar, one thing to remember about multiple myeloma is that actually the average age that people get diagnosed with multiple myeloma is around 70 years old. It's actually a little bit earlier in some communities, but on average, it's about 70 years old, meaning that the average person who gets diagnosed with multiple myeloma is an older person. Also, it's important to know just because that person has lived almost 70 years, it's important to know that they may have what we call comorbidities or other health issues that might be unrelated to the cancer. A third thing to know is that people who have multiple myeloma are what we call immunocompromised, meaning that their immune system is just not as strong as those without myeloma. And those things are very important, especially when you talk about a COVID pandemic. So what did we do differently? How did we take this vulnerable group and basically try to improve their outcomes during COVID? Some of the things that we tried, we're trying to implement things like telemedicine. We tried to make sure that we counseled patients as well because what you told patients in 2019 was very different than what you told them in 2020 and 2021. We got creative as far as the testing that we had to do for patients and even had to go as far as considering different modalities of treatment just to kind of reduce exposure. One of the important things that is important for any cancer, but specifically multiple myeloma, is clinical trials. And how did clinical trials really play a big role in COVID and multiple myeloma? Let's start with telemedicine. So people probably never heard of this term telemedicine before COVID came out, right? But now since then, it has been exploding and really everywhere. One of the things that we try to do is we try to initiate what they call virtual visits, meaning that previously it was very important for me to lay hands on you, put my stethoscope on you, listen to heart, lungs, all these different organs, but then the world stopped and things changed. Now it is important for me to listen and hear you just as important as actually seeing you. So we actually developed these virtual visits that we were actually able to really connect with patients, hear their stories, hear what's happening, and actually see them. And that's really led to improved outcomes. One of the important things with multiple myeloma is that there's actually an inactive version called smoldering myeloma where people might not actually be on treatment. Or, as we know is very important in multiple myeloma, the maintenance stage. And so we had to kind of really figure out how do we take these folks who may not be on treatment or be on a very stable treatment and decrease their exposure to the healthcare system by basically trying to figure out, do they really need to come into an academic center just to get labs? Can we utilize their local facility? Or there's some patients who are able to get blood in their home and actually faxed or sent electronically over to our healthcare system for us to review. Again, one of the important things with treatment is unfortunately side effects and symptoms. Are we able to gauge those side effects and symptoms with a simple phone call or video? One of the important side effects of one of the medications for multiple myeloma is Revlimid or Pomalyst. These medicines have an important side effect such as rash, and how we treat the rashes differs depending on how widespread it is. So using videos and those kind of things were very critical at helping us figure out exactly what to do with patients without them actually being in the office. I think it was really a person by person or patient by patient evaluation that the doctor wanted to do, but really our main goal was to decrease exposure. During COVID, one of the things that kind of came out was the different variants. And one thing that we learned is that different variants have different symptoms. And so what we had to do as the healthcare system is try to figure out which symptoms were mild, which symptoms were more severe. it was sometimes rather challenging because we had to figure out, is this an actual symptom of some of the chemotherapy medications that we prescribe? For example, one of the medicines that's very common in multiple myeloma treatment is a medication called carfilzomib or Kyprolis. This medication is associated with the pneumonitis. So if someone called us saying, hey, I'm short of breath, us as the providers and the doctors had to figure out, is this something related to actually COVID? Or is this something that's actually related to one of the treatments? We also had to figure out which patients had to be hospitalized with COVID, because as you know, just because you had COVID doesn't necessarily mean you had to be in the hospital. And so these are very important nuances that really, especially as the pandemic was very beginning and at the beginning, and we really had to learn more about it, we had to kind of figure out. Also, one of the important treatment modalities or treatment decisions in multiple myeloma management is stem cell or bone marrow transplant. And so, like everyone else, we thought maybe COVID would be over in a mere matter of weeks or months. So some patients decided, let me push off my stem cell or bone marrow transplant for a couple months, thinking that COVID might be over. But then a couple months turned in a couple years. And unfortunately, we're still dealing with some of the consequences of COVID to this day. And so delaying transplant really became an important decision of, is now the right time? Is now the right time? Because we know that even though patients are immunocompromised from multiple myeloma, that level of immunocompromise does get more severe during times of transplantation. Also, we had to kind of figure out, are there different treatment decisions that needed to be done to actually improve patients' outcomes? For example, if there were some oral medicines that patients can take in their home and have the same outcome, maybe that might be preferred as opposed to having them come in once a week for IV. Common example, dexamethasone. One of the common medications that's commonly given with multiple myeloma is steroids, typically dexamethasone. Dexamethasone can be given as an IV or an oral therapy. So during COVID, I think it really made sense to us for us to, again, decrease exposure and try to figure out that maybe oral therapy might be preferred as opposed to having someone come in for an IV therapy. One of the common questions that I get is actually, do I need to have my immune system replaced? There is a replacement called IVIG or IV immunoglobulin. And one of the things to know that even prior to COVID, this was something that was given to patients who had a low immune system and had recurrent infections. One of the things that multiple myeloma patients will know is that we check their immunoglobulin levels called IgG. If those IgGs were low and someone were to have continued infections, then we could actually replace that IVIG. And sometimes that really led to improvement in outcomes. However, during COVID, we really tried to figure out, does this help? And unfortunately, to this day, we really haven't seen very strong evidence that there's a specific indication for, low immune system or low IgG to replace it in the setting of a COVID infection. One thing that we're very cautious of is that all medicines have side effects. And one thing to note about the IVIG is that it does increase your risk for thromboembolic events. And so we always try to make sure that we do no harm. Close monitoring is always required. Let's talk about vaccines. Once the COVID pandemic came and we kind of learned more about it, adjusted some of our treatment management, then we had to learn, do we give vaccines for myeloma patients? We don't know. So let's talk about some of the information that we did learn. This slide is very busy, but just know that before we knew that these medicines would have an effect, we had to compare them to what we call healthy controls. So if you look at these slides, you see the letters HC. HC stands for healthy controls, meaning that those are patients whose immune system should be very robust, as opposed to people having heme meaning a hematologic or blood-related disorder, such as multiple myeloma. One thing to know is that for the COVID vaccine, one thing that was very important is what they call this spike protein. And if you developed antibodies to the spike protein, typically you were able to actually mount a response and actually do well with treating COVID. As you can see in the healthy controls, at 1 month versus 3 months, typically it takes a couple months for even the healthy controls to mount a substantial response and gain enough of these spike antibodies. Unfortunately, we didn't see that same peak in some of our hematologic patients. Even at 3 months, unfortunately, that same robust immune system response was not able to be seen. So we also looked at those patients who had prior infections. As you know, the use of the COVID vaccines was very controversial, especially in patients who had already had a COVID infection. The question was, do I still need the COVID vaccine? So we studied that and tried to look at these spike proteins or spike antibodies in healthy controls versus those who had these heme or blood related disorders. At 1 and 3 months, we see that really people who even had the COVID vaccines were still able to have these spike antibodies present, and that they did not have a waning immune system. But unfortunately, in those who had a hematologic or blood related disorder, we did see that those antibodies were lower than those who, the healthy controls, even at 3 months after having a COVID infection. So the ability to fight off a COVID infection in someone with a blood or bone marrow related disorder such as multiple myeloma does decrease over time. An important question then that we also found out was, does treatment matter? Do those patients who are on chemotherapy or off chemotherapy, does that matter at all? And we actually found out that actually those, as you can see here by the graph, those who actually were off of chemotherapy at 3 months were able to kind of mount more of a response than those who unfortunately who were on treatment. So we know treatment does play a major factor. As the vaccines rolled out, there were multiple different companies that were trying to develop different vaccines. This BNT162b became the Pfizer vaccine, and we also wanted to compare that to the other option, which was the mRNA 1273, which was the Moderna vaccine. So, because another patient asked us the questions, well, if I have the option, Pfizer versus Moderna, which one should I choose, doctor? And so we had to unfortunately figure that out because we didn't know at the time. And so what this shows that there were some patients who had the mRNA 1273 or the Moderna vaccine that at 3 months after vaccine administration were able to produce a more robust of a anti-spike immunoglobulin response. Then we had to learn, is there a difference male versus female? And so, as we can see, again, with females at 3 months after the vaccination, females did have a more robust immune system response, even at 3 months after vaccine administration. And then also, because we talked about multiple myeloma being a condition of aging, we wanted to find out, well, what happens in people who were younger? Did they still have any differences? And we did see that age did play a major factor, whether those patients who are less than 50 did have a more robust of an immune system response and were able to have higher levels of anti-IgG antibodies around at 3 months after vaccine administration. Because we know that not all blood cancers are the same, sometimes we get lumped into the same category, but one thing that we wanted to delineate was what happens with different blood cancers. For example, there's a blood cancer or bone marrow cancer that's very important called leukemia, right? We looked at patients with leukemia, patients who have cancer actually in their lymph nodes called lymphoma, and then this multiple myeloma, and tried to figure out, did we see any differences? And unfortunately, all of the responses were poor. But as you can see, patients who had leukemias and multiple myeloma, unfortunately, did have very low rates of this antibody production. If we focus this talk on multiple myeloma, then we can circle down to figure D, where it basically shows, does the different types of treatment that are available in multiple myeloma matter? So if you look, there's some people, as I mentioned before, who have multiple myeloma or even an indolent version of it called smoldering myeloma who may just be on observation. As you can see, those patients who are on observation or not really on active treatment did have higher levels than those who are on other treatments. For example, there's a group of medications, Revlimid and Pomalyst, called IMiDs. Those patients had a very different response than those patients who are on anti-CD38 medications like Darzalex or daratumumab. Unfortunately, we also saw that people who had what we call BCMA or B cell maturating antigens, such as CAR T cell or BLENREP, those patients unfortunately also had a lower chance of actually developing these antibodies. So just know that in summary, the treatment does matter. And we did notice that even within patients with multiple myeloma, the types of treatment that they were on mattered, and did they mount a response to the COVID vaccine. Oh, this is very cool here. So one thing to know is that not only do you want to develop these spike antibodies, but you also want to make sure that you can neutralize or kill whatever COVID you may get presented with. So it's one thing to know that, hey, my body has COVID antibodies, but does it also have the ability to kill COVID if being presented with COVID? And as you can see here, we took healthy controls, and at 3 months, nearly 90 to 100% of the healthy controls really had a strong amount of these killing antibodies that, if presented with COVID again, should be able to neutralize them. Unfortunately, we did not see the same thing with patients who had blood or bone marrow related disorders. That really you can see even at 3 months, unfortunately, a large amount of patients did not have adequate numbers of immune response. Also, this graph shows that if we broke it up into different quartiles, so if you look at quartile three is really where you want to be. That's where you have enough of that spike protein and enough of that killing or inhibition of COVID that you can really kind of do something to actually protect your body if you get exposed to COVID. And unfortunately, as you can see, there's a lot of yellow in this. Yellow is for who? The healthy controls. So where do you see the most pink? Unfortunately, down in quarters 1 and 2, meaning that if quarter 3 are the people who have the best response to not only the vaccine, but if they were to get the COVID infection again, would have actually some type of killing effect. Unfortunately, we just did not see that for patients who had multiple myeloma. Actually, it was very similar with all the other blood-related disorders such as leukemia and lymphoma, but unfortunately, we also see multiple myeloma patients did not fare as well when it came to their ability to kill those types of infections. This slide may be a little difficult to read, but this is also very important because not all myeloma patients are the same, right? So we talked about previously that treatment mattered, meaning that what drugs you were on at the time matters. But one question that came up was, do people who are newly diagnosed differ than patients who have been through multiple lines of treatment? And we noticed that actually those patients who got exposed to the COVID vaccine and were in their newly diagnosed or what we call frontline therapy actually had a much better response than those who did not. Another thing that's very important to realize is my disease under control matter? Meaning that we looked at patients who were in what we call a complete remission, right? And we show that they actually were able to have higher levels of COVID antibody than those who were in what they call a partial remission or not in complete remission. Then graph C also looks at if you take someone who is in at least a partial remission and compare that to someone whose disease is progressing or someone whose disease is stable, we found that those who have a partial or a complete remission did show much higher levels of this anti-spike or higher levels of COVID vaccine protection. And so it does matter where your disease is and where you are in your treatment as far as how you responded to the COVID vaccine. So what risks did patients have, And so this is very important as well because now we talked about the vaccine, we talked about the management difference, but what about the actual patients themselves? And so there was a study that basically showed that the main problems with COVID are people who ended up on what we call an invasive ventilator or death, meaning that there's people who have to be on a machine, which is called a ventilator, where the machine actually breathes for them, okay? And we saw basically significant differences in patients with cancer compared to those without, who actually ended up on this ventilator machine or actually died from COVID based off of them actually just having cancer as a condition. Because as we talked about before, there's other comorbidities that are associated. One important thing to remember as well is that not only was COVID found to be important or to be a major factor, not only was cancer found to be a major comorbidity or a major factor, it was also the use of steroids. As we talked about before, one of the main treatments for multiple myeloma is steroids. And so we see that some of the major things that are related to our condition of having blood-related disorders and even the treatment themselves did place patients at an increased risk for having severe complications from COVID-19. This is important to know because I think that people get sometimes stuck in trying to figure out exactly what exactly is happening. This is a good summary slide. So who are the people who are at risk for having complications or dying from COVID? One, patients who are older. Two, patients who have different racial backgrounds, okay? Patients who have what we call hematologic malignancies. Patients who have what we call progressive cancer or growing cancer, and those patients whose functional status is very weak. All right. So if you look at these kind of conditions, it's really the people who unfortunately have multiple myeloma. And if you have a progressive type of multiple myeloma or a more advanced type of multiple myeloma, unfortunately, your risk is just that much higher. Also, one thing to know that they actually did not find that the use of certain what we call cytotoxic therapies actually did not show any difference in having this increased severe COVID reaction. One thing that people also talk about, especially in multiple myeloma, is the risk of having surgery. As we know that surgery is very important, especially if people have bone fractures or other complications that come up with the disease. And so we actually showed that surgery versus no surgery, there was no difference. Radiation therapy. Unfortunately, because this disease can sometimes be very debilitating and involve the bones, radiation therapy is very important. And so we looked and actually did not find any significant increase in radiation therapy, which I think plays a very important part of myeloma therapy. So let's talk about, really from a patient standpoint, what are some of the things that I think are very important for people to kind of remember and, during the COVID pandemic. Number one, should I come to the doctor? Should I continue my treatments? Do I need to put this off? I would say honestly, the answer is no. By now, we really have been very savvy at figuring out what treatments, what type of modality works best for people, and actually delaying multiple myeloma treatment, unfortunately, can lead to worse outcomes. Multiple myeloma has certain effects on the kidneys, certain effects on your blood counts, certain effect on your bones, that really delaying treatment, unfortunately, could lead to worse outcomes. The doctors may talk to you about oral versus IV treatment. A lot of times, those things are very equivocal, meaning that it wouldn't matter necessarily or really change any outcomes if you got a pill versus an IV drip, and your doctors would talk to you about that. One thing that we should also talk about before is those elective procedures. As I mentioned before, things like surgery, radiation, those things are very important in myeloma care. And actually, we have data now that we just presented showing that really there's no difference in it worsening COVID outcomes. One thing to always remember as a patient, social distancing is very important during the pandemic. Hand hygiene, actually surface hygiene, okay? Wearing masks and really being able to identify respiratory symptoms and communicating that effectively with your doctor. One thing to also know that if you were to suspect that you have COVID infection or some type of illness, unfortunately, you can spread that illness, especially if you bring it into a cancer center. So sometimes isolating yourself and really letting your medical team know that you have these problems really could be life-saving for other patients. One thing to note with being in the hospital versus out of the hospital. Sometimes we may not admit you to the hospital, we may just see you in clinic. We really try to do what we call virtual medicine or what these call virtual visits. That's really a way to integrate technology and healthcare. One thing that we always try to do, whether we're in or out of the hospital, is to do social distancing and do what we call PPE. Sometimes you might see your doctor wearing goggles, wearing a mask, maybe even sometimes a gown, but that's really not only to protect him, but it also may protect you and sometimes even the next patient, because as you know, the doctors have to see multiple people. You also might see certain doctors wiping down iPads or computers a little bit more often because we're really just trying to keep things safe. So this is very important. So there unfortunately sometimes becomes too much of a burden on the healthcare system with COVID, meaning that because you have cancer, you might need to go to the emergency room because you're having some problem or situation. But unfortunately, sometimes hospitals actually get full of patients having COVID, and unfortunately, they may not have a bed available at your local ER or hospital to actually treat you. And so this becomes very important because they have to prioritize some of these things. And unfortunately, that leads to longer ER wait times and longer times for people to actually be seen. We also know that for us as the healthcare workers, our job is to really try to make sure that we're there for you and that we are here to support you through your cancer journey. As you know, because we have to live in this world, we also kind of have been affected by COVID as well, sometimes working longer hours. And so we do recognize that we are here to be there, not only there for you physically, but emotionally to kind of help support everyone through these trying times. Thank you for your time today. I really appreciate this discussion, and hopefully you learned something about really how COVID has really changed the landscape of multiple myeloma, and now you have some of the facts and information just to do that. Thank you for your time.
Dr. Blue, that was a wonderful presentation, and I'm sure that our patients with multiple myeloma and their family and caregivers have gotten a lot of information from what you have said. A couple of things that stood out to me was that the information that you passed on to us probably could not have been generated without clinical trials. So, years ago, one of the reasons I left private practice was to go to the university to try to improve the accrual of minorities onto clinical trials. And so obviously I have a lot in my heart for clinical trials, but it's obviously critically important. Is there anything else you want to say about that?
I think the main thing that patients come to me and tell me is that there's a misconception about clinical trials. People think clinical trials are for when there's nothing else. When I've tried all the normal stuff or the regular stuff, and then they say, now I'll do a clinical trial. No one was expecting COVID. We didn't know how this was going to affect what we call healthy controls as opposed to people with cancer. And then if you look at patients with cancer, blood cancers, these are things that we did not know. And the only way that we learn things as a science community is really through research. Clinical trials is the main way that we do that research because we have to know if we're going to give you something, or me as a doctor, if I tell you that, hey, this vaccine is likely going to help you, I want to at least have some kind of leg to stand on or some type of evidence to say, yeah, I actually not only believe that, but here's something that shows how well it works. And so the only way we can do that is really through learning about it, doing some type of research, and clinical trials, I think, is really the way to go. So I think if people are on the fence about it, just know that that's the only way that the doctors can be sure that this can potentially help you.
Absolutely. One of the other things that I thought about as you gave your wonderful presentation was the CDC has fluctuating recommendations in terms of how we should go about our lives with regard to COVID precautions. Those precautions don't always apply to patients who have multiple myeloma. So, are you recommending that that the patients and their families speak to the doctors and really not follow quote unquote CDC guidelines because multiple myeloma is a different situation?
Yeah, so actually, there's two very important things that you mentioned there. Number one is that science changes. All right. So when I was a boy, we actually learned that there was a planet called Pluto. All right. I have a third grade son. Did you know that Pluto is no longer a planet? Meaning that Pluto is still there, but fortunately, the science has changed so that what used to be the case and what was actually taught in school is no longer the case. And the same thing is happening. It's just happening at a much faster pace. It's much happening a little bit more public that really, as we know more as a science community, then we do, it's an old saying, if you know better, you do better. And there was so little that we knew at the beginning, we had to say something. But as we learned more, as things evolved, we really had to kind of fine tune some of those guidelines. And even now, we're not getting it right all the time, but at least we're trying to change based off of the information that we have available. That's number one. Number two is, where do I get my information from? So it's important for people to realize multiple myeloma is a rare condition. I always tell people, think of it like this. What is your favorite sporting event? Let's just say good old American football. The Super Bowl was just last month. If you take a Super Bowl stadium full of people, out of that whole stadium, only about 10 of those people will have multiple myeloma. There's no way that we would have this amount of information on just those 10 people, just because it's such a rare condition. So when someone gives, information out, typically it's for the other people that are in that stadium, and it might not actually apply to those 10 people in the stadium just because of what they have is so rare. So that's where it's important to have that important doctor-patient relationship. It's very important a lot of times even do what we call a second opinion. If your doctor locally may not know, odds are there's a what we call an academic or a big institution close by where you actually might have myeloma specialists, meaning that people who devote their career to just seeing one disease. And so I think that's where those types of things are important. And I think especially now that we're doing virtual visits, the access to doctors like me who are what we call myeloma specialists is through the roof now. You don't have to drive all the way hours away. You just get on your computer or your phone or your laptop, and then you can actually ask those important questions that actually pertain to multiple myeloma.
Let's go back to your stadium reference. If a small percentage of those people would actually have multiple myeloma, what did you say, 2%?
It's 10. Typically, it's about 10 out of 100,000.
Okay, so let's say that. Would there be a difference in terms of the racial composition of those people?
Yeah, so I'm glad you brought that up. So the question is really, who is myeloma affecting, right? So unfortunately, we see myeloma affecting people of African descent, all right? So black patients, unfortunately, are having a higher burden of multiple myeloma compared to those who are from European ancestry. Not only that, we also see that there's differences in how we do, meaning that if you take a black patient and you take a white patient, unfortunately, sometimes we don't do the same, meaning that we don't live as long with the same disease that's actually diagnosed at the same stage. Also, we learned that African Americans actually get the disease earlier. I talked to it and kind of alluded a little bit in my presentation, certain groups getting the disease younger, but really that's African Americans and black patients. And so that's really important for people to realize because, you know, what's happening to someone who's earlier in their life? They're still working. They may not have Medicare. Their retirement savings aren't fully, invested in, and the time to kind of come back and forth to doctor visits and really, being malleable, sometimes that's very important. The 50-year-old patient and the 70-year-old patient are much different, Also, too, for Hispanics, we're actually learning in some new evidence showing that Hispanic patients actually get the disease at a younger age as well. So these are minority groups, unfortunately, who have been attacked and very vulnerable outside of cancer. Now you throw in a cancer that unfortunately is not curable and saying that they have differences in outcomes, that just lets us know we got more work to do.
I took care of a fair number of patients with sickle cell disease back in my career, and we realized that sickle cell, the gene change in sickle cell was actually protective of malaria back in Africa and other Mediterranean countries. Um, and that was why, people developed sickle cell. Do you think we'll find out that actually there was a genetic change that was protecting us from something uh, that causes us to be so susceptible to multiple myeloma?
You know,
I
that's
mean,
very interesting.
I know that's really putting it out there for you, but I just bring it up to say that I know people are doing research trying to figure out why the discrepancy.
Yeah, I think that's the problem, unfortunately, with having such a rare condition, is that we just don't have the numbers sometimes to make those types of claims. And so I think that as we evolve more, the thing about the internet is that the internet has brought communities of people together who really weren't talking before. The person in Florida and Seattle really didn't have a way of communicating about their treatment, about their diagnosis, about their symptoms. But now the internet, there's social media platforms. There's a big array of different ways for people to get together and to learn. Even through this symposium here, this is a way that's virtual. We may have people logging in from all over the world, and that's a way for us to put information together and learn from that information. I think that we don't know things now because it's so rare. Our hands were so tied back then. As you can even see in your treatment lifetime, you've seen this disease change like night and day. And so what we knew even 5, 10 years ago is much different than what we know now. And so I think that if you look towards the future looks very bright. So hopefully we can answer some of those questions, and I'm definitely excited about that.
Right. Um, what about the Promise study?
Yeah.
Can can you give us an idea? I mean, patients, are interested in that. I
Mhm.
think so. If you could give our listeners some information about that, I think that would be helpful.
Fantastic. So, really, what we're trying to figure out is familiar patterns of multiple myeloma and even the precancer called MGUS, all right, or monoclonal gammopathy of undetermined significance. We know that African Americans or people of African descent have actually higher rates of this precancer. So if you have higher rates of a precancer, what's going to happen down the road? You're going to have higher rates of the actual cancer themselves. But what we're trying to figure out is this nature versus nurture? That's the whole question. Is this a social economic issue, or is this something actually in the biology of people of African descent that makes it a problem? So what the PROMISE study does is that if you have a parent, a child, or any sibling with multiple myeloma or the precancer MGUS, then what you can do is that you can basically not actually be the patient, you can be a loved one and go to promisestudy.org. All right, you sign up. We actually send a kit to your house. You take it to your local Quest, which pretty much wherever you live in the United States, you have a Quest diagnostic lab, and then we actually send you results that basically say, are you at risk for this precancer condition? And then that'll help us learn familiar patterns, community patterns, and actually get more information. I think that's the issue with myeloma right now, is that we're walking blinded. We need more information to actually answer those questions. And so if we do promise study, meaning that if your brother has myeloma, you might not have it, but your brother has it, sign up for promise study. You can find out, are you at risk? If your mama had it, then you don't have it. But no one knows. They never checked you. Go to promisestudy.org. You can find out. If your kids have multiple myeloma and you're the parent and you want to know, you know, are you at risk? All right, go to promisestudy.org. If you are a loved one with someone who has this condition, don't just sit on the sidelines. Be active. Go to promisestudy.org and learn, are you yourself at risk? Because we want to learn, is this showing up in families? And if you are at risk, then you can actually get the help that you need before it attacks your bones, before it gives you the kidney problems, before it attacks your blood counts, before all the complications arise. You want to make sure that you attack things early and not when it's too late.
Again, it's been just a pleasure to have you here with us. We are always happy to see new, young um, hematologists who are interested in multiple myeloma. We're going to get to where we want to be one day, I believe. We just need to keep doing the research and keep doing the quality care. So, again, thank you for your participation. And I wish you great luck at Moffitt.
Thank you so much. And I just hope that people learn something today and that really, hopefully the pandemic will be over soon. But we've been saying that for 2 years now, but really, at least because it's still here, people learn how to manage not only themselves, manage their loved ones, and get some information to really benefit them, because what you don't know sometimes can hurt you.
Thank you, Dr. Blue and Dr. Hicks, for bringing your passion and commitment to discussing this disease. Even though we are seeing numbers decrease, it's still important to remain vigilant, especially with the possibility of new variants arising. And just a reminder, please make sure you're watching the chat box to see if you are one of the raffle winners. On to our second session now. We have Dr. Craig Hofmeister, Associate Professor of the Department of Hematology and Medical Oncology at Emory University School of Medicine. And he's no stranger to Hicks Ferguson, as he was one of the first presenters in the early years of this symposium. He played an instrumental role in getting information out about multiple myeloma in the African American community. Dr. Hofmeister will be joined by his former colleague and another past symposium presenter, Dr. Yvonne Efebera, Director of Blood and Marrow Transplant and Cellular Therapy at OhioHealth. They will share the progress on multiple myeloma clinical trials and their effect on care.
Thank you so much. I have the greatest pleasure of introducing my colleague, Craig Hofmeister, who is an associate professor at the Department of Hematology and Medical Oncology at Emory University. He earned his medical degree and his Master of Public Health in Clinical Investigation from the Ohio State University in Columbus, Ohio. He completed his internship and hematology fellowship at Loyola University. He's board certified in hematology, and his practice focuses on plasma cell cancers, including plasmacytomas, multiple myeloma, AL amyloidosis, and smoldering myeloma. Dr. Hofmeister's research focuses on early drug development and investigator-initiated clinical trials, exploring novel diagnostics and treatments. As a translational researcher, he has been funded continuously from the National Cancer Institute since 2016. Dr. Hofmeister previously worked at Ohio State from 2006 through 2017. In fact, him and Don Benson hired me in 2009 to join the myeloma group. It was the three of us, and the three musketeers, I shall say, and I was the only lady in the group, and I can tell you I was spoiled. Without further ado, Dr. Hofmeister, such a great pleasure to see you again.
Hi, hello, and thank you so much for that kind introduction from Dr. Efebera, who I have not seen in person for a few months, and I'm excited that she was realizing about my new haircut. I'm certainly a little more aerodynamic these days, and she's always such a stickler for details. But anyway, thank you so much for the invitation from the organizers. And today I wanted to talk about clinical trials in multiple myeloma, but in cancer in general. I think many of these same challenges we see for clinical trials in myeloma apply for clinical trials in cancer in general. And when you think about these challenges that we have for clinical trial enrollment, we have system issues, we have patient level issues, and I want to talk about system issues first before we get down to the nitty-gritty. First, some data about the problem. If you look at the enrollment for clinical trials that support cancer drugs from 2011 to 2016, you can see outside the US on the left-hand side and within the US on the right-hand side. If you look at the racial makeup, you can see in blue the vast majority of patients are white, a small sliver are African American, Asians are in gray, and the yellow color there is Hispanic. This is not a diverse clinical trial enrollment and highlights problems because the adverse events and the efficacy are based predominantly on one category, and that's not what we're looking for. If you get closer and look at myeloma trials in specific through a larger period of time from 2000 to 2016, and you look at people of color, on the left-hand table, you see that it's 84% white, 8.4% African American, and 2.8% Asian Pacific Islander. Again, it's not like myeloma trials don't fit within standard all cancer drug approval trials. The problems we have in myeloma are reflective of problems we have with all clinical trials. And on the right-hand side, it focuses on trials specific to the sponsor. If the sponsor is a pharmaceutical company, that's called industry. If the sponsor is a National Cancer Institute, that's the second row. And if the sponsor is a university or a cooperative group of universities, that's the third row. And you can see that the proportion of African Americans increased from 5% to 10% and 8.6%. So it's a little bit better if the sponsor is not a drug company, but really this is not the type of diversity you and I are looking for in clinical trials. And when you think about how well do these clinical trials reflect the population, you can see the incidence there in the top row, and you can see that 60% of patients that have myeloma are white. You can see 20% are Black, Asian, and Hispanic in the top row. You can see the mortality roughly reflects the population that are at risk of developing myeloma. But then the third row down, this is the enrollment. This is where patients are on clinical trial. You can see more whites, more Asians, and far fewer Black patients make it onto clinical trials. And this is one of the things that we need to fix. Fixing it is such a task because where we are coming from is so far from where we want to be. And we are somewhere in the transition between those 2 points. And anyone who talks about clinical trials and equity often starts with the Tuskegee syphilis trial. Now, this trial, for all the details on this slide, was really a trial that wanted to look at patients with syphilis and wanted to see the natural progression of the disease. What's tragic is that it was a trial where they withheld necessary treatment, and even at the beginning, when they were enrolling patients, they didn't want to provide treatment. And in fact, they coerced and tricked patients to get sham treatments during the whole trial for years. And if you truly want to question organizations of authority like the CDC, like the AMA, they supported continuation of the study decades after it was known that penicillin was effective, after they knew that they were withholding appropriate treatment. And thank goodness, this eventually came to light. There were lawsuits, and 1974 was a banner year where things were settled, and this spurred a lot of reorganization and fixing of the research complex so that ideally no clinical trial like this ever gets planned ever again. Now, think about 1974. That was the first research fix-up that said, hey, patients deserve protection. They need to maximize benefits. They limit harms. Everything here needs to be essentially patient-centered. 1975 is where they wanted to have protections for unborn. 1976, this is protection for prisoners. And prisoners used to be a huge, completely non-volunteer clinical trial population where many, many drug companies experimented on prisoners against their will. In 1977, there were protections in place for children. In 1978 is the process we use now, where we use institutional review boards made up from both science experts, but also patient representatives and regulatory bodies, so that clinical trials are now planned and since then have been planned with the idea that it's really the patient that should be the center. Despite all that oversight, 2006 on the right-hand side and 2016 on the left-hand side Still mistakes happen. These aren't necessarily equitable mistakes. These are sometimes planning mistakes given new investigational treatments where sometimes the toxicities catch up. And on the left-hand side, you can see that patients were getting a treatment to look at anxiety, to lower pain, and unfortunately, once they raised the dose, they enrolled a cohort too quickly. And all the patients who were enrolled in a cohort at a new dose suddenly became horrendously ill. 1 died, 5 went to the hospital, and on the right-hand side, a 2006 trial, all of these patients also became horrendously sick because they enrolled the entire cohort of patients all at the same time. So while these types of errors don't focus on equity, we will always try to improve clinical trials, and there always can be improvement in thinking about how we enroll and how we can maximize safety, maximize learning, and decrease the risk to patient harm. So I started off with kind of a shocking beginning of the Tuskegee clinical trial that started in the early 1900s, and now we're in 2022. And many of my patients still have a strong suspicion about institutions, a strong suspicion against clinical trials and so-called human experimentation. And from a system perspective, not just an individual perspective when you're with the patient, but how can we make clinical trial access equitable? And things we can do are very concrete. We could set targets for enrollment such that every clinical trial is, at its very fundamental basis, it's equitable. It requires a certain number, a certain type of patient to be enrolled so that we can understand toxicities and efficacies as it varies amongst these groups. We could increase resources available so that grants are made specifically to study diversity and lack of diversity in clinical trial enrollment, and try to look at pharmacokinetic differences between patient groups, how we all metabolize and get rid of drugs when they're in our body. Maybe that's different between groups, and a lot of that certainly has not been studied yet. Not only do we need to put resources to motivate scientists, but we also need to make sure that every person that a patient encounters along the road from seeing the doctor to getting on a clinical trial looks like they do and is adequately represented. And that is a huge problem, because if you go from one doctor who doesn't always fit to another staff member and nobody looks like you, it's going to be hard to be comfortable with this process and sign on to something experimental. Now, that's the system level issues. But these issues are different than the issues you have when you have the patient in the room, you're looking them in the eye, and you're saying, what can we do to talk about this clinical trial that is patient-centered but supportive? In myeloma, every patient with FDA-approved treatment is going to relapse. There's a 100% likelihood that they're going to relapse if something else doesn't happen. And so what better cancer to think about clinical trials? Because there are really two options. You can get standard treatment, which you know is 100% risk of failure, or you can try something new. Now that's severely one-sided way of looking at it, but this is not plastic surgery where you're looking at a clinical trial to do something that is optional. Your patients with myeloma didn't deserve to have this, they didn't want it, but they're there. They need treatment, and if it's newly diagnosed, their first relapse, second relapse, third relapse, the opportunity to get investigational treatment and potentially, ideally, a better treatment with fewer side effects needs to be considered, and may not be the fit for every patient every time, but it's something to consider. And really, it starts with the idea that only about 3% of myeloma patients ever enroll on a clinical trial. And one of the strange thoughts is that we may have a much better drug or group of drugs available that's available even now, but because we haven't been able to enroll quickly enough and study patients' side effects and study what worked and what didn't, we're giving our patients much less effective drug cocktails than we could have if instead of 3%, we had 93% of patients enrolled on clinical trial. We would be able to make scientific and medical advances so much faster. So there are misconceptions, and let's go bit by bit. So one is that clinical trials are riskier, and this comes up every day in my clinic because if a patient looks at consent form, it's 20 pages of legalese and side effects and gobbledygook that is scary. And they have the idea of doing this scary clinical trial, or I can just go over to that infusion center and you're going to give me drugs and that'll be better, right? But actually, that's not better. It's just because we don't necessarily always give patients a long list of side effects that they're going to have with standard treatment. And so clinical trials needs to be balanced in terms of what's in a consent form against what you do standard, and trying to make sure that patients understand where are the additional risks, where are the additional requirements, and how that's different on a clinical trial versus standard of care is very important. Most of my patients say they don't want to be a guinea pig. And I think that one of the best ways to respond to that, because a clinical trial is at its very essence experimentation, is to emphasize to patients that they are the center. The protocol and the trial is not what's important. They are what's important. And we are advocating for each patient to get the best treatment and the best experience. And if something doesn't work out, we want to make sure that, unlike a guinea pig, they need to feel like they are in control. And they need to feel empowered to both take part in a clinical trial and not take part in a clinical trial as they see fit. And when they're in a clinical trial, to either continue on or to hop off. Most patients and many doctors think that clinical trials are only for patients who are end stage, who've been treated and relapsed many times, and for which there's not even a possible other drug. But in effect, we are trying to improve myeloma therapeutics in patients who are newly diagnosed, patients who are setting for transplant, patients who are at their first relapse, second relapse, third relapse, etc. There are clinical trials for each one of these steps and supportive trials all along the way. So there's no area for a myeloma clinical trial experience where we are not interested in doing it better. Most doctors are not going to mention clinical trials, especially in the field of myeloma, because most of them don't do myeloma full time. And if you don't do myeloma full time, if it's only 2% of what you see on your average day, your institution and your own brain is not going to have the bandwidth to do something specialized. So many patients who see local oncologists who have only a brief number of myeloma patients, many of them we suggest, hey, let's come to an area that focuses on myeloma, that has many myeloma clinical trials, so that you can see what are the options and what could you take part in and what are the risks and benefits. Most oncologists are trained very similarly, but some oncologists go on to be able to treat mostly breast, lung, colon, prostate cancer because that's the majority of their job. And some oncologists go on to treat just one cancer. And sometimes you want your doctor to be able to have breadth, but be right next to you, 10 minutes away. And sometimes you need somebody who's a specialist, even if they're an hour or two away. And that's where a general oncologist can help you in some ways, but a myeloma specialist can help you in others. The trial is never more important than the patient, and we want to emphasize that at every aspect for every decision, that it's the patients who have control about whether they continue on, they stop off, and we never want a patient to feel that how the trial is going is more important than whether they're getting a response and whether it's a good fit for them. one of my younger patients looked at a number of clinical trials on clinicaltrials.gov and was annoyed at the selection of trials, feeling that many of them were motivated primarily from pharmaceutical companies that wanted to see something from A plus B versus B plus A. And she said, that's not that interesting to me. I'm interested in something that's truly inventive. And I think we need to have open and honest discussions with our patients about what attracts them to clinical trials and what are they interested in, because not every trial is a fit for every patient. Nobody wants to get the placebo. There really are very, very, very few trials in the plasma cell disorder perspective where placebos fit. And so the vast majority of trials for myeloma have no placebo. Everyone's always petrified about this, that I'll treat their myeloma with a sugar pill, and I promise that's never going to happen. So bottom line, just to review some of the key things about clinical trials, is that clinicaltrials.gov is a challenging website to use to figure out if you have a clinical trial appropriate for you. There are clinical trial search engines focused just on myeloma. So sparkcures.com is one of them. And it's sometimes hard to figure out, hey, what's available at the time, because these trials open and close. Most of the time you need to show up at a myeloma center if you want to see if they have a clinical trial. And when you're thinking about a clinical trial, what you often want to focus on is not necessarily the side effects, because the side effects are usually similar to the standard of care side effects. What you want to know is, how many times a week or a month am I going to have to go to the cancer center? What extra procedures are involved? Most of the reason that patients don't participate in clinical trials, if they have the opportunity, is that the geography is too punishing. They may know a clinical trial is available, but they can't possibly make a 4-hour one-way trip to a cancer center twice a week. That's just too much. Most of these clinical trials have a specific doctor attached to it, and that specific doctor is associated with the clinical trial. They get credit for the accrual. Some doctors and some practices get money for every patient that they accrue. Let's be honest about what we're all getting out of this, because in every clinical trial, the patient is trying to get new therapy that ideally has fewer side effects. The doctor's trying to accrue to get either publication credit or something, and the pharmaceutical company is trying to bring their drug to FDA approval or to expand FDA approval. Let's all be honest about what motivates us in this clinical trial sphere. And the last thing is that try not to worry about the 50 pages that a clinical consent could involve for a trial. What you want from your doctor is to know, what are the big side effects that I should expect, because the list of potential side effects for almost any drug goes on forever and is not terribly helpful. And what's more helpful is if the doctor can point you towards what are the few most common side effects I'm likely to have, because if that's not acceptable to you, maybe that clinical trial is not right. All right, so that's it for my quick talk today. Thank you so much for your time and attention.
Well, thank you so much, Craig, for that wonderful, presentation and an awakening to clinical trials, and really how limited it is to people of color, African Americans, Hispanic, and Asian. Even though multiple myeloma affect twice as many African Americans as Caucasians, the number of clinical trials participation is so low, and really a great eye opener. So as someone who has been a lead accruer, and I'm a testimony to that in clinical trials, how would you approach an African American patient for a particular study? Keeping in mind you being a Caucasian and they thinking about past experiences or experiences of their families and friends. How do you talk to them in that 6th grade level so that they understand that you're not really shoving a clinical trial in their face?
Thank you so much for the question, and that comes up a lot in my center, and it's never lost on me when I'm walking into the room how much what's similar and what's the same in that room. And if you don't acknowledge it, you don't talk about it, it's not helpful. And I think the first part of the interaction that is important for any patient and doctor is establishing trust. If a patient thinks that the clinical trial is more important, or the institution is more important, or my relationship with the referring doctor is more important, all those things are not what I want to convey. What I want to convey is, in the room at the time, they are the only thing that matters to me. And establishing that trust is critical. But that trust has to carry over. And that trust you have to carry to the next step. And sometimes it's going from me to a clinical research coordinator to talk about the clinical trial and review the consent and review the details. And that then it goes to a staff member who's doing potentially a bone marrow biopsy, or somebody who's giving a survey. Everyone along that route needs to display that same push, that the importance of the patient and their outcome and their side effects and their wishes are the number one thing. And some things you can change and some things you can't. And you can change your attitude, but I can't change the fact that I'm white as snow. But we can change at Emory, we can change what we do, and at Ohio State, we can change what we do to increase diversity in the faculty, to increase diversity in the clinical trials office. There are tried and true ways to decrease bias in the hiring process. And while that is a longer term investment, it's not going to help you today when you're talking to a patient, it is going to make sure that the patients, when they come in, have people that look like them. That helps the comfort, helps the cultural awareness and agreement, so that that view of trust and patient-centered behavior is carried through.
Thank you. That's that's so true, and I see that in my practice. I think being someone of African American and talking to an African American patient, they feel more comfortable with me. And of course, while I was at Ohio State, we had more African American accrued in clinical trials than we ever did, because, as you said, it's so important for a patient to see someone that looks like them as part of their treatment group. Thank you. And the other question I have is that how do we increase the number of African American, Hispanic participating in clinical trials? And one of the things that you brought up is access, and the reason for that is one of the major reasons is transportation. Many patients live in rural areas where there is no academic center, and so one of the things that I have brought up before with pharmaceutical company is bringing the trial into the community and increasing the community, maybe having a combined clinical trial with a community's center and the academic center. Say in a transplant trial, patients can still get their treatment in the community, but also is in connection with the academic center, and they work together with the research coordinator working between the two. What is your thought on that, or any other ways to limit how far patients have to travel for a clinical trial, because that's a huge problem.
Right, and it's I couldn't agree more. It's a big problem in Ohio. It's an even bigger problem in Georgia, because the main academic center is in northwestern part of Georgia, and some patients will drive 4 hours from Valdosta, Georgia, all the way to Atlanta to get part of specialized care or to part of a clinical trial. And that's one way. When you're sick, With relapse myeloma, oh my goodness. While Ohio has multiple academic centers spread throughout, that's not the way in Georgia and in many states. The geography in the U.S. is punishing. I don't see a easy way to necessarily overcome geography. I wish I did, but there are some things, like you said, where you can have partnerships, especially in more common cancers, to allow where you can expect, somewhat simpler trials in breast and colon and prostate and lung cancer to work with private practitioners in rural communities. And there's some technological advances. So for instance, if you had potentially a phase 4 trial after FDA approval, and then you wanted to be able to check metabolism and excretion of the drug, there are patches that technologically are now possible. So you can do PK trials where patients aren't in the academic center and they can collect these blood vials at home without needles. There are some technological advances that have become available over the last 10 years to improve the amount of testing that can be done from afar. And who would have thought that you could potentially do a phase 1, or phase 2 clinical trial with the patient never coming to the cancer center? It sounds crazy, but I think there's some ways to potentially do that now. It's not perfect. It's a little bit bumpy. But there's some ways to get closer to the world where geography is not such a barrier.
What are your thoughts on maybe a pharma-sponsored trial, making a commitment to say this particular study, we want so many, 20% of African Americans to enroll in this trial. We have to allocate this number of slots for a patient. We will not close this trial until this percentage of slots have been designated for African Americans or Hispanic. And I know some pharmaceutical company, as I am advisor on some of these boards, are trying to make an effort to increase these numbers, but I know there are some companies just want their trial to enroll quickly, right? That's how they get their drugs approved. Mm-hmm. But give us your thought on that.
Well, some of you may not like this thought, and I apologize in advance. But people, pharma companies, they're responsible to their shareholders, and they're going to do whatever makes them the most money the fastest. So on the regulation side, it should be a requirement. Not that one trial has that, and we're hoping for the largesse of a large pharma company to say that 20% of their accrual should be Black. No, that should be every trial, and it should be required. And any cancer trial, let's say, just focusing on cancer as we do here, every trial, phase 1, 2, 3, they all have to be much more diverse than they are today. It's a requirement. You can't register on clinicaltrials.gov until you make that part of your trial. So I know that there are many who dislike this idea of regulation and big brother, but I think diversity is incredibly important, and without it, I just don't think we're going to be where we want to be.
Yeah. And I know I said that was the last question, but just one more. What do the African American community need to do to increase their enrollment in clinical trial?
Again, this may be an unpopular answer. I don't think the African American community needs to do anything. The rest of the world needs to create a system that is less discriminatory, less limiting, and more patient focused, so that these patients get access to the same treatments that I get access to. And there is only one zip code in the United States that doesn't discriminate against Blacks. And that's horrendous. And if you think that doesn't happen in a hospital, you're crazy. And you think it doesn't happen in the cancer center, that's ludicrous. Our African American community doesn't need to do anything different. I think we, outside the African American community, through process and structure, need to limit bias so that the overall survival of Black myeloma patients and Black patients with any disease are the same as they are for white patients. And it's ludicrous to have any other goal. So I don't think the community needs to change. I think everything outside them needs to change.
Thank you.
Thank you so much.
Thank you, Dr. Hofmeister and Dr. Efebera, for sharing the importance of participating in clinical trials. It was also great seeing the two of you present together again. We appreciate you joining us today. Well, I hope that you have enjoyed our symposium thus far. What a wealth of knowledge and hopes for finding a cure. As we approach the end of our program, don't forget to check the chat box for final chat raffles. We're now at our last session, the inaugural series, My Personal Journey, Living with Multiple Myeloma. It showcases a patient, caregiver, family, and others sharing their journey. This series will be held a few times throughout this year, so check the calendar of events in the program booklet. Joining us for this inaugural session is committee member Stanley Harris and moderator Kimberly Alexander. So please join me in welcoming Stanley and Kimberly to the symposium.
Thank you, Jerry, and the HHF Planning Committee. Today we are joined by Stanley Harris, a multiple myeloma patient who retired after nearly 4 decades in the banking industry. Mr. Harris, tell us your personal experience with multiple myeloma from the day you were diagnosed until now.
Well, in December 16th, 2016, I was given the news that I had contracted multiple myeloma. Was in the hospital, transferred hospitals, went from Mount Carmel to Wexner. And once I got to Wexner, they had a treatment plan already put together based on information that Mount Carmel had sent to them regarding my health and test results and so forth. They immediately started chemotherapy, and really for the next 3 months, I had weekly treatments, and then I went in for a stem cell transplant. Was in the hospital for 3 weeks around that. I stayed a week, probably longer than I would normally have stayed because I ended up with an intestinal infection, which was no fun. But we got through that and came home and then started recovery. Once again, my treatments were weekly for, I think, a month. And then we went to biweekly for another month and then monthly after that. And was going along for about 1.5 years. Things were going very well. The cancer seemed to be pretty well controlled. And then all of a sudden it started to expand again. And so they switched my treatments, and I actually went into another whole combination of treatments. And that's been working very well for the last 2 years.
Wonderful. So how were treatment options offered to you? Did they explain to you why there might be a reason why you have to try different combinations from time to time?
It wasn't really until we got to the point where the cancer was growing again that we got into a longer discussion about the options that they thought that would be available to me, including a couple of different trials. And they recommended one, and it's the one that I'm on, and it's worked very, very well. I've been in remission now for a little over 1 year.
And so what made you open to being a part of a clinical trial? Because especially in our community, that's a really big issue. A lot of us are very nervous and skeptical about being involved with clinical trials.
Yeah, and as it turned out, the trial that I was in, I was actually the first patient from the Wexner Center to go into this particular trial. But I think there were a couple of things. One, I think the doctor's confidence in the combination of medicines that the trial was composed of, she seemed to be very confident that this could address my particular cancer where it was at that stage, and that it had the trial, the patients in the trial had very, very good results. So that was one. And then, of course, the other thing, which is probably almost as important, is the fact that in the clinical trial, the drug manufacturers, they pick up pretty much most of the cost. So there's no out-of-pocket cost associated with that. Prior to that, it was costing me almost $2,000 a month. That's expensive. I think between the two of those, but I would say the underlying cause really was just the confidence that my oncologist had in the trial and the medications that were a part of that trial.
Were you suggested to go maybe like check out other nonprofits or do any other research on your own, or were you primarily getting information from your physician and his team?
It was mostly the physician and his team. Of course, Dr. Hicks, who had been my personal physician for a number of years, we always consulted him uh, pretty much every step of the way, and he was generally reinforcing what my oncologist was recommending. And then, of course, I've gone to all of the HHF conferences, and again, that's always provided a lot of information for me. Again, reinforcing to a certain extent what I was hearing from my attending physician.
What do you feel is important for people to know about myeloma?
Well, I think the one thing that has stuck in my mind, and that is every cancer is unique. What's happening with me may be very, very different from what's happening to someone else who's been diagnosed with multiple myeloma. So you can't get caught up in your progress or lack of progress and someone else's progress or their lack of progress. It's just a completely different ballgame. I think the thing that amazes me is that the various medications out there to treat the disease still has a way of figuring out what your issues are and then obviously attacking it on that basis.
So, do you have any personal insights that could help healthcare professionals or policymakers better understand what it's like to live with multiple myeloma, especially during a pandemic?
Well, I think with the excuse me, with the pandemic, the big key is you just cannot be um, too careful in terms of trying to shield yourself from catching COVID. And unfortunately, I know as I've kind of moved around the city, whether it's going to the grocery store, or the barber shop, or the church, or other places, I'm just amazed at the number of people who refuse to wear masks. And so, with my immune system being what it is, and it is what it is, you just have to be very, very careful where you're going and how much exposure you're allowing yourself around other people. My church has been very sensitive about the chances of COVID, and so we've been very, very conservative and restrictive in terms of people having to wear masks while they're in church. You have to have the mask on when you come in. There's no exceptions. We were taking temperatures for a while. We've been social distancing and all of those things, but you just don't find that everywhere else you go. So things like catching a plane or going on a cruise or even a train ride, those are just not on my agenda these days and probably won't be for quite a while.
Yeah, and that's totally understandable. I'm curious to know, how is it making you feel now that the restrictions are seeming to be lifted? If people were already kind of iffy about it, now that it seems as if the restrictions are being lifted altogether, Do you feel like this is something or a way of life you're going to have to live with for a while just to, remain safe?
For me, the easy answer is yes. While I'm very pleased to see that the disease seems to be going, the number of people who are catching it seems to be going down, the numbers are still too high. And again, with everybody trying to, the authorities relaxing the mask mandate, it still kind of makes you a little nervous because once again, everywhere you're going, there's nobody wearing masks. I mean, I've been pleased in the few restaurants I've gone to that at least most of the waiters and waitresses, they're masked, but none of the customers are. And you walk in with the mask on, and you're sitting there with the mask on. People kind of look at you a little strange, but you quickly get used to that. But it's just disappointing that people have gotten so lax in working against this thing that I believe that it's going to take a much longer period of time for this to really go away, if it ever goes away. And we just have to be very careful.
Now, if I remember correctly, I spoke with your wife before about her journey as a caregiver, and you all
Mhm.
had a friend or a pastor who had been
Yes,
diagnosed with myeloma. How do
our
you think
pastor.
how do you think learning about his diagnosis helped you in dealing with yours, or did it? Did the information you had, received during his lifetime with myeloma, did that help you in any way?
Well, first of all, before he was diagnosed, I had never heard of the disease. So just, with him being diagnosed and announcing that he had the disease, that was news. And then of course he and I had discussed what was the nature of multiple myeloma, and he was able to explain that for me. And believe me, when I was diagnosed, I mean, it was, the first thing that occurred to me is what is the likelihood that the pastor and I both end up with this disease, uh, a disease that we'd never heard of. And there was no direct connection for me getting it or he getting it as a result of our friendship. But I think as we went along, I knew about the stem cell transplant because he had gone through it a year before I was diagnosed. And we had talked extensively about what that was like for him. So I was very much prepared for what I was going to go through in my own situation. We traveled two different paths in terms of treatment and the results of the treatment. So, like I said, no two cancers are alike, and that's a classic example. We had the same oncologist, but she was diagnosing and treating two different paths.
So, in light of how hearing his story helped you, do you find that encourages you to share your story with other people now?
Oh, absolutely, absolutely. And I hope it is helpful to not only those who may be diagnosed with it, but for those who just have the interest. I'm very happy to do that.
So, are you proactive now about like keeping up to date with what's going on in the space of myeloma? Do you keep up with like new treatment options, or do you just kind of take a seat back and wait to hear from your physician when it comes to possible options in the future?
Well, I see my doctor formally once a month, and that is some of the things that we talk about in the sessions that we have. So yes, I'm definitely interested.
Well, before we wrap up, is there anything else that you'd like to share that you would love for myeloma patients and even caregivers and family members to know about what it's like to live with myeloma?
Well, I would say first and foremost, a good caregiver, and I have a great caregiver, I think is very, very important, probably almost as important as the medication that you're taking to treat the disease. I would not want to go through this without the caregiver that I have. So there's no question about that. That role is vital.
Well, thank you, Mr. Harris. I think that's about all the time that we have today. Your contributions are invaluable. I believe that sharing this information can really be a game changer, especially for our community. So thank you again.
Great. Glad to do it.
Stanley, thank you for sharing. I'm sure our multiple myeloma patients and caregivers appreciate the transparency about your journey. Well, I don't know about you, but for me, that was some amazing information sharing. We hope that you were able to jot down several takeaways about addressing COVID while in treatment or remission, how and why clinical trials are important to ensuring what treatment works for you, and hearing Stanley share about his journey with multiple myeloma. We know all multiple myeloma individuals are different. Circumstances vary. However, HHF's goal is constant: to impart reliable, accurate information so our participants will know their options and have resources to make decisions that fit their situation. So before we move to the closing, I'd like to thank the Hicks-Harris-Ferguson Planning Committee for this opportunity to participate as their MC for this amazing event. Cheryl and I had a long history with addressing health disparities and health equity issues. She was one of the most compassionate and caring people I've ever met. It was an honor to be here today. And I wish you all the very best as you progress to finding a cure. Up next, as we end this awesome symposium, Jerome Ferguson will return for our closing remarks, and he'll be followed by Reverend Meyer for our closing prayer. Thank you again, and I wish you all a blessed rest of your day.
What a program! On behalf of the Hicks-Harris-Ferguson Multiple Myeloma Symposium Planning Committee, we thank you. We appreciate you for spending this time with us today. We do appreciate your continued support for this symposium. Without it, we are not able to put a national face on this disease, to be better advocate and a support for those affected with this disease. I want to thank all of our presenters for graciously sharing their time, talent, and stories with us today. Every year, we continue to be inspired and encouraged by the new health trends and how patients are living life well with this disease. Finally, the HHF Planning Committee would like to thank our sponsors and supporters. We greatly appreciate your continuous support for the symposium. In closing, please do not forget to complete the event evaluation that will launch after the symposium, and reference your digital program for the exciting events that we will be hosting throughout 2022. Wishing you a very blessed rest of your day, and we hope to see you during one of our upcoming events.
Lord, as we have come to the end of this symposium, we give you glory and honor for the lives of these men and women that spoke to us today. Thank you for gifts and talents. Thank you that they could share it with all of us. Thank you for the organizers that have worked tirelessly on this production. Bless them and bless their families. God, I know that your thoughts towards us are of peace and not evil, to give us a future and a hope. We believe that it is your will that we live free from all diseases. Lord, by the authority given to us, we declare that the infirmity of cancer with all its many forms and common types are destroyed in the name of Jesus. Lord, as the body of Christ, we declare that our members who have been diagnosed with cancer will not die, but live to tell what you have done. Lord, comfort those who are mourning the loss of loved ones. Be their comforter by day and their song in the night. Praise belongs to you, and we honor you for such a time as this. Healing, strength, and resilience we claim in your name. As we part from this virtual space, do not depart from us. And now may the grace of God and the love of our Lord Jesus Christ and the fellowship of the Holy Ghost be, rest, and abide with us all. In the name of Jesus, and the children of God say, Amen.